Now, I'm not an expert on pernicious anemia or B12 deficiency. Martin's put me on as the warm-up guy for the experts who are going to be following, and we're going to hear some very interesting stuff today. In fact, I'm not even a practicing GP now. I've been a GP for 40 odd years, but I retired about 6-7 years ago. But when I was a GP, I always felt a bit uneasy about pernicious anemia. You know, it was rarely at the front of your mind. And, you know, a patient would come in, they complain of feeling tired and weary, and you'd just do, you know, a basic full blood count. Maybe, you know, the hemoglobin was a little low, but all the other parameters were normal. You know, the red cells were not tiny, they weren't big, so there was no macrocytosis going on there. And of course, now we know that pernicious anemia can be present with a normal MCV. And patients coming in, you know, feeling tired, I think the feeling amongst a lot of GPs is a sort of heart sink feeling, oh God, another one. And you very often see in the patient records, TATT, tired all the time, which they complain of. And of course the GP replies, yeah, well, so do I feel tired all the time. But they don't find an answer in the sort of basic blood test that they perform. And then of course when you diagnose pernicious anemia in a patient, you know, you start them on the B12 injections. And of course, in my early days, the advice was to give the injections every month, following the initial loading dose. Then it changed to every 2 months. And now it's every 3 months. Now, I don't know where the science is to show that every 3 months is the correct procedure to follow in treating patients with this condition. And I don't think Martin's been able to find any evidence anywhere on the 3 months. Yeah. So anyhow, they're the regulations. Of course, you put the patients on injections every 3 months, and what happens? They come back at 2 months when the symptoms are there. I'm feeling tired again, I'm exhausted, I'm feeling weak. Oh, well, you can't have your injection for another month yet. And that happens again and again. But in fact, basically what I did is I just said, well, the patient's telling you their symptoms, you know, the symptoms are coming back, well, give them the injection. Maybe it's a month early, maybe it's 2 months early. What the hell? I mean, what damage are you going to do? It's not an expensive treatment. And yet a lot of patients are held down to their injection every 3 months. Now, in explaining the DAT FC, okay, I was a medical student, but I have to confess, I was not very studious. I come from a small mining town in the northeast, Wall's End. It's the end of Hadrian's Wall, just outside Newcastle. And I came down to Manchester Medical School. Well, what a transition that was at the age of 18, going from a little mining town to a bright lights, big city. And of course, you're surrounded by everybody your age. And this was the 60s. You know, a very exciting time to be a teenager. So wow, when I got down to Manchester, this was absolutely brilliant. And I really devoted myself more to the social scene than the medical student working scene. And I was social secretary of the medical school. I ran a rock group, I had a mobile disco, which there were not many of them around in those days. And the organisation was that in going through the medical course, you were joined up with another student as a partner, and you went through the whole course together. You were dissecting the bodies in anatomy together as a team, and there'd be another 2 on the other side, so it'd be 4 of us to a body. And you'd work through the whole course. And in fact, my partner, he would sign me in for many lectures, which I wasn't there for. Now, don't tell anybody this, it's confidential, okay? So we got closer to finals, and I realized that, God, I'd been missing ward rounds and not attending lectures. You know, what the hell am I going to do? So I thought, well, the odds are the cases you get, you're not going to get some rare tropical diseases. You know, common conditions occur commonly. So I thought, well, I'll start looking at the common conditions. But then the medical tomes, you know, are huge books, and there's no time, 6 weeks before final, to go through these. So I evolved a scheme thinking, well, you know, you're given a patient, what's the patient complaining of? Shortness of breath. So I started making lists, 12 causes of shortness of breath, 10 causes of tiredness, you know, 8 causes of jaundice, and just had lists and lists of causes of those symptoms. And I had little notebooks. God knows how many of them I had that I could carry in my pocket and just learn the list and learn the list and learn the lists. And then I evolved it further into DAT, FC, which I sort of termed my eliminator list. Eliminate these conditions. You've got the patient in front of you, and you go through the eliminator list. DAT, could they have diabetes? Could they have anemia? Could they have thyroid disease? The next DAT, drugs. Could it be the medication that's causing the problems? Could it be interactions between medications? Could they be taking medications and buying stuff over the counter and causing interactions? And medications, you know, can be causes of many, many symptoms in patients. And then the final T of that, that was so drugs, sorry, A, alcohol, could there be alcohol related here, and T, tobacco, because smoking causes so much pathology. So there are your 2 DATs, and the FC, F, family history. Is there a family history of these symptoms of this condition? And finally, of course, cancer. So using that eliminator list, it was quite a sort of basic way of approaching a patient to see, you know, could it be any one of these conditions? And if any of your family members are ill or friends are ill, try and remember that FC yourself. Could it be diabetes, anemia, thyroid, drugs, alcohol, tobacco, family history, or cancer? And I remember one of the early ward rounds that I did go on, the professor there was called Professor Boyd, and I don't know if any of you can remember the films from many, many years ago, the Doctor series, Doctor in the House, Doctor at Sea, and there's a character there, Sir Lancelot Spratt, big guy, huge personality. Well, that character was based on Professor Boyd at Manchester University, who was a character, and he was a real clinician. He wanted to diagnose patients clinically rather than depending on pathology results, lab results, and the piece of paper. And he said to us, he said, look, he took us onto the ward round, having given us a talk beforehand about using powers of observation. He said, look at the patient. When they're describing to you their symptoms, look at the patient. You'll see things. For example, you know, he said, you might see a little tremor in the hand, could be Parkinson's. You might see signs in the face. There might be a slight lemon yellow tinge to the whites of the eyes, indicating liver problems. There might be 1 or 2 lumps on the ear, which could indicate gout. He says, have a look at the earlobe. There could be a transverse crease across the earlobe, and you'll all be doing this later. Finding a transverse crease across the earlobe indicates a possible presence of arteriosclerosis, increased collagen and depositions within the arteries, increased risk of heart disease and stroke. So, you know, God, this is great. And he said, you're a doctor detective looking for signs. And apart from looking, listen to the patient. They'll virtually tell you the diagnosis if you're up to scratch. Listen to the patient. And to him, the patient came first before the piece of paper. He was a tremendous clinician. And so he took us to the first patient, and he said, well, this patient actually got diabetes. And the patient complained of weight loss, excessive thirst, passing urine frequently, and a sweet tooth. And he said, you know, these are the sort of classic symptoms of diabetes. So he said, well, how would you test this patient for diabetes? Oh, blood test, blood glucose. I said, no, before doing a blood test on the patient, of course we didn't know the answer to this. He said, well, they've got high blood sugar? Yes. Well, they're passing a lot of urine. Why? To get rid of the excess sugar out of the body, so the urine contains sugar, really when it shouldn't. So on the side of the bed was a beaker of urine. So he said, well, how would you test that urine for glucose? Oh, a dipstick, just dip it in, you see a change of... He said, no, not even using that. There's sugar in there. And then he passed it round, this ring of students, and, you know, and when we'd all tested it adversely, he then said, remember, I told you about looking and powers of observation. Had you been looking carefully, you'd have seen me insert my index finger and lick my second finger. Never to be forgotten. Excuse me while I have a drink of urine. So certainly impressed upon us, you know, the importance of clinical evaluation in the clinic, using your eyes and using your ears. So coming on to pernicious anemia, B12 deficiency. You know, the patient comes along to the GP, they complain of tiredness, weakness, fatigue, and you examine the patient, you don't find much, so you send off a blood test, and it comes back, and maybe the hemoglobin is slightly low, but you know, the red cells are normal size. They're not small as you'd find in iron deficiency anemia. They're not enlarged as you'd find in pernicious anemia. So the, you know, the MCV is normal, and the patient is sent away. I'm sorry, you know, your tests are sort of pretty normal here. There's not much to worry about. Off the patient goes. Now, let's just look at the guidelines of the British Committee for Standards in Haematology with regards to B12 status in pernicious anemia. And I quote, "The absence of a raised MCV cannot be used to exclude the need for B12 testing, because neurological impairment occurs with a normal MCV in 25% of cases, and yet we're sending them off untreated." The next guideline, and I quote, "Some tests may give false normal results." And the third guideline, "Neurological symptoms due to B12 deficiency may occur in the presence of a normal MCV." Very important statements. So a normal MCV does not exclude B12 deficiency. Now that patient, maybe they've gone off and not very happy, and they've come back, you know, 6-7 months later, they're still TATT, tired all the time, but they've got some pins and needles in their fingers and their feet, sore tongue, mouth ulcers. So the GP does the full blood count and then does B12 estimation. I'm onto it now, pernicious anemia. Now, in fact, when you look at the guidelines again, and I quote, "The clinical picture is the most important factor in assessing the significance of test results, because there is no gold standard test to define deficiency of B12. No gold standard test." And I think you'll hear more about this during the day. "It is not entirely clear what should be regarded as a clinically normal serum B12 level. In the presence of discordances or disagreement between the test results and the strong clinical features," what the patient has told you, "strong clinical features of deficiency, treatment should not be delayed to avoid neurological impairment." So the serum B12 test is not a good indicator of a patient's B12 status. and the treatment should not be delayed to avoid neurological complications. A GP then starts the patient on the B12 injections, as I mentioned earlier. And the guidelines say that standard initial therapy for patients without neurological involvement is 1,000 micrograms intramuscularly 3 times a week for 2 weeks. 3 times a week for 2 weeks. It's a loading dose. Patients presenting with neurological symptoms, they're much further down the line, should receive 1,000 micrograms intramuscularly on alternate days, until there is no further improvement. Now, I don't see that happening an awful lot, or I didn't see it happening an awful lot in my day, which of course some years ago. Maybe it's changing. Let's hope it is. But in the guidelines, in these guidelines, there's no mention of how often the patient should be receiving the B12 injections. Should it be 3 months, 2 months, or 1 month? So that's missing from these guidelines. And there's no mention if symptoms return before the next injection is due, what we should be doing. And of course, if the patient's coming back 6 weeks after their injection and they're not due for another 6 weeks after that, give them their B12. They respond extremely quickly. You've got feedback pretty quickly there. And the final guideline is patients with pernicious anemia need treatment for life regardless of serum B12 levels. Regardless of B12 levels. I mean, it's a shambles. And then when you introduce, say, the intrinsic factor antibody test, it gets even more sort of shambolic. And I don't have time to cover that area in this presentation, and I know it's going to be touched upon, later today. Now, B12 deficiency, I mean, it's widespread. 20% of the over 60s have B12 deficiency. And that group is getting bigger because we're living longer. So about 3 million people over 60 have got B12 deficiency. The same number, about 3 million people under 60, have B12 deficiency. A B12 deficiency can be caused by various things, inadequate diet, gastric surgery, gastrointestinal surgery, medications, DAT, D stands for drugs, medications. Medications causing B12 deficiency. Treatments used to control acid, proton pump inhibitors, omeprazole, lansoprazole, which can be bought over the counter without seeing the doctor. Ibuprofen. How common and how popular is that? Metformin, simple, cheap treatment for type 2 diabetes, and the contraceptive pill. I can imagine the scenario of a 30-year-old woman, she's on the pill, she was recently diagnosed with mild type 2 diabetes, so she's taking a metformin, her joints are aching a bit, so she's buying herself ibuprofen from the chemist. That's causing a bit of stomach trouble, so she treats herself by buying lansoprazole over the counter. Whoa, hello, B12 deficiency. It could be on the way down the line towards her. But of course, the main cause of B12 deficiency in the Western world is autoimmune atrophic gastritis. Pernicious anemia is an autoimmune disease. Autoimmune diseases where the immune system attacks its own tissues. And that results in various diseases. I've actually got an autoimmune disease, celiac disease. It was only diagnosed about 4 or 5 years ago, and I'm 71. But it's been there all my life without knowing. And having one autoimmune disease increases your risk of other autoimmune diseases. So you could have a patient who's maybe got a B12 deficiency, but there's an autoimmune disease in the family. FC, family. There's a family history of autoimmune disease. Could that patient have an autoimmune disease such as pernicious anemia? Now, I'd like to just touch lightly upon thyroid disease, because underactive thyroid disease, to me, is not dissimilar to pernicious anemia. The patient comes in with symptoms. They're tired, they've got weight gain, they're constipated, they're thinking very slowly, they feel the cold. Listen to the patient. They're telling you the diagnosis, query underactive thyroid. And then you're looking at the patient. What do you see? You know, thin, coarse hair, puffy face, strawberries and cream complexion. You have a pink colouring of the cheeks. So maybe the GP does thyroid function tests. The thyroid function tests come back showing the thyroid hormones are within the normal range. The paper says they're within the normal range. You haven't got thyroid disease, love. Next. And the patient's left untreated. This is not an uncommon situation when you talk to patients with underactive thyroid disease. Not dissimilar to pernicious anemia. Your paper results are okay within the normal range, therefore there's nothing wrong with your love. So, with thyroid patients, I know what I used to do. If they had, normal blood tests, but they had the obvious symptoms of underactive thyroid, I would give them thyroid hormone, a therapeutic trial for 3 months, and see what happens. This is not lifelong treatment, a therapeutic trial. And patients can respond quite quickly, as they can with B12 injections. A therapeutic trial of B12, is that unreasonable? Doesn't seem dangerous, it's not expensive. And you'd find out pretty quickly, if there's going to be a response. So it's a very frustrating area to work in, pernicious anemia and thyroid disease. And one other guideline from that list. The clinical picture is the most important factor. The clinical picture is the most important factor in assessing the significance of test results. So basically, patient before the paper printout. So I'd like to finish by drawing your attention to the vision of the PA Society. And that is to achieve a world that understands the nature and consequences of pernicious anemia. Maybe that could be rephrased. Maybe a vision of a world that provides accurate diagnostic tests for pernicious anemia and a treatment protocol dependent on patients' symptoms. Thank you very much.